All right, good morning, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And today I'm talking about vestibular migraines. This is an exciting topic as I treat a lot of patients who have dizziness disorders. I have a lot of patients who have rocking and bobbing and swaying sensations. And many of them have been diagnosed with Maladé-Barkman syndrome. I just did a Facebook Live on this. And now I'm going to talk about vestibular migraines because vestibular migraines are very important to any patient who has episodic vertigo. In fact, vestibular migraines are now widely acknowledged in the literature as the most common cause of episodic vertigo, which is pretty interesting. So it's an underdiagnosed issue. We are looking for a biomarker for this issue, we being the scientific community and doctors and clinicians. I'm going to talk about an article that may have found that biomarker, and hopefully this will help you to understand why you're having rocking sensations or dizziness or episodic vertigo associated with headaches sometimes and not with headaches sometimes. So, as I just mentioned, episodic vertigo. This is a great article for any of you who are interested in, so to speak. This is by Marianne Dietrich. Dr. Dietrich is one of the world's foremost researchers on vertigo and dizziness. I believe she is out of Germany, and she's probably one of the top 5 researchers in this domain of neurology. This article is fantastic because she goes through vestibular migraines since the inception of the diagnosis and how it's still being underutilized as a diagnosis. For example, primary care doctors refer patients to ear, nose, and throat specialists and neurologists for the issues of dizziness and vertigo. 1.8% of the time of those referrals, so let's say they refer 100 people, only 1.8% will they think have vestibular migraines. But by the time they actually see an ear, nose, and throat specialist or a neurologist who is adequately trained in diagnosing these dizziness issues, which sounds kind of like an asinine comment. I don't mean it that way, but somebody who's really experienced in the dizziness and vertigo world, they'll find that upwards of 20% of them will diagnose the patients with vestibular migraines. So the GP only thinks 1.8% have vestibular migraines, but in actuality about 20% do. And she says she thinks it's even more common than that. So the interesting aspect of this, let me go down. Okay. Within this article, there are a few nice figures which depict how you diagnose a vestibular migraine. How is a vestibular migraine different from your standard migraine? Let's just go through that. Your standard migraine is a unilateral, typically pulsatile headache. It can be bilateral. It inhibits activities of daily living. Lots of times it's associated with light or sound sensitivity. Oftentimes people have to conceal themselves into a very dark, quiet room. There may be nausea, there may be vomiting, there may be an aura where they see, there's changes in vision and scintillating type things or zigzags in their vision. They may see things like that, they may not. And there may also be other neurological symptoms like double vision or numbness or tingling on one side of the face or body, things of that nature. That's your migraine headache. How's a vestibular migraine different? Well, a vestibular migraine is someone who has a history of migraine or currently has migraines, and or they have moderate or severe headaches at least about half the time that they have dizziness. And they typically have light and sound sensitivity, and they may have a unilateral pulsating headache. But in order for it to be a vestibular migraine, it seems a little more loose, and some people say they have to have vertigo. Well, what is vertigo? Vertigo is typically referred to as a room spinning around somebody, but really it means the illusion of motion. So if somebody is rocking or bobbing, that's an illusion of motion. So that can account for vertigo. Nonetheless, what I'm trying to say is that if you have a nebulous, moderately severe headache, and it happens some of the time when you're having vestibular symptoms like rocking or swaying, and sometimes there is no headache when you have your vestibular symptoms and you have light and sound sensitivity and you have a history of migraine, well, you're probably looking at a diagnosis of vestibular migraine. So it's a little more wide in my perception. and that's why it's not being adequately diagnosed. But the Brawny Society, which is basically in terms of neuro-otology, meaning neurologists who focus on the inner ear and ear, nose, and throat specialists who focus on the inner ear, the society is saying vestibular migraines are the most common cause of episodic vertigo. Okay, so one of the studies that Dr. Dietrich cited involves the basal ganglia. Now, this diagram is from the Principles of Neuroscience, totally separate textbook, but I brought this in to the discussion to illustrate the basal ganglia. The basal ganglia are these deep control centers in the brain for movements, most notably described, but also for eye movements, thoughts, and emotions. Well, your inner ear actually fires through the thalamus in a very similar area as do the basal ganglia pathways fire through. Here's just more depiction of different parts of the anterior cingulate area and medial orbitofrontal cortex and how they fire in to the basal ganglia. And note, in essence, you have brain tissue up here firing through this deep portion of the basal ganglia. One is called the direct, the other is called the indirect pathway. They go through the thalamus. Now, the VA, ventral anterior, and the ventral lateral nucleus of the thalamus ties in with the cerebellum. And here you see that here, VL, VA, that's what that refers to. And in the study, Dr. Dietrich talks about how the thalamus actually lights up in vestibular migraine patients. Why? And they found it was the VA nucleus of the thalamus because, in essence, there's sensitization, there's over-activation of vestibular pathways going through the thalamus. So that's kind of interesting. You also see it here in the occipital lobe as well. Okay, now this is a really interesting topic, and I'll try to stay on course, but there's a lot of discussion right now. If you look at Meniere's disease and you look at Maladé-Barkman syndrome and vestibular migraines, are they overflowing conditions of one same problem? And to illustrate that point too, let's just think about migraines. Think about somebody who has a migraine who has light sensitivity. Well, what's going on in their brain? They're sensitive to light. So those pathways that encode vision are oversensitive, simply, or their occipital lobe is oversensitive. In fact, the occipital lobe has been found to have high levels of inflammation during vestibular migraines. I digress. But, so if visual information is oversensitive in your standard migraine, is it vestibular information that is, or vestibular areas of the brain that are hypersensitized during a vestibular migraine? That's a possibility. Now, they've seen a high correlation, or they've seen overlap between Meniere's disease, which are individuals who have ringing in their ear, they have pressure in their ear, and they tend to have vertigo lasting hours, sometimes days, and vestibular migraine. And one thought is that are all Meniere's patients actually experiencing vestibular migraines? Because they've seen similar microscopic findings in the inner ear in Meniere's patients as they would see in a migraine patient in other areas of the brain. They call it extravasation of certain inflammatory polypeptides, or different chemicals. So it's interesting here in this study because they took patients with vestibular migraine, audiological findings in patients with vestibular migraine and migraine history. History of migraine may be a cause of low tone sudden sensory neural hearing loss. So one of the key differentiating factors between vestibular migraine and Meniere's disease is a low tone hearing loss. Well, here they found in this article that vestibular migraine patients also have low tone hearing loss. So again, the lines are getting blurred. I did a video many months ago saying that there's new imaging modalities where they can actually go in and see if the inner ear is swelling, as is seen in Meniere's disease. It's called endolymphatic hydrops. And with this 3T gadolinium enhanced MRI, and they can actually see the inner ear swell in Meniere's patients. But now there's even some thought that that swelling of the inner ear is actually a vestibular migraine. So basically, there's an inflammatory process. There's, the blood is not being flushed out of that part of the brain and then the inner ear, and as a result, that's why the inner ear swells. So I'll keep talking about this, but that's not the main point of today's discussion. In Dr. Dietrich's article, she talks a lot about all the studies done on vestibular migraine and medication prophylaxis, meaning medications that can help to prevent the vestibular migraines. And this was one study she cited. Basically, metoprolol is a blood pressure medication, and this study was discontinued because in essence it wasn't helping. And there aren't a lot of definitive studies showing that medications help vestibular migraines. There's some evidence, but nothing overwhelming yet that one certain medication is a medication to help those of you suffering with these headaches and dizziness disorders. Again, not a complete lack of information, but nothing definitive yet. So self-motion perception is sensitized in vestibular migraine. I'm just going to back up, and on that point of the medications, I'm not prescribing them, but I'm just saying that is what Dr. Dietrich discusses. If you have questions on that, read the article, send me comments, things of that nature. So this is a fantastic article, and I just talked about it on a Facebook Live with Maladé-Barkman syndrome patients who are individuals who travel by boat, plane, or car ride, and they come out of that experience then feeling as though they're rocking, swaying, or bobbing for more than 1 month. And it's an awful illness because they always feel like they're rocking, and sometimes it just happens out of the blue. It's called spontaneous non-motion triggered Maladé-Barkman syndrome. But the interesting facet is that a study out of UC Irvine, they took 15 Maladé-Barkman syndrome patients and they treated them with vestibular migraine meds, meaning they used like Topamax and Verapamil and amitriptyline and a few others, and they saw that 11 of the 15 improved in terms of their Maladé-Barkman syndrome symptoms. So then the question is, well, is Maladé-Barkman syndrome really vestibular migraines? And so that came from the journal Laryngoscope in 2017, and that has prompted a lot of discussion. And so I would say, not in my experience, I don't think all cases of Maladé-Barkman syndrome are vestibular migraines, but there certainly is some overlap that we have to pay attention to, because a lot of you vestibular migraineurs have this sensation of rocking or bobbing, along with these nebulous headaches, and you're light or sound sensitive, and you had migraines when you were a teenager. So you can see that these things are overlapping between MDDS, vestibular migraines, and Meniere's disease. But in this article, Dr. Susan King and her group out of Harvard, basically, they're in Boston, Massachusetts, they're affiliated with Harvard, studied vestibular migraine, and they compared vestibular migraine patients to your standard migraine patients, to Meniere's disease patients, to normal controls. And they, in essence, were tilting their head in a variety of planes of the semicircular canals and the otolith organs. What does that mean? You have 3 semicircular canals. You have a horizontal, you have an anterior, and you have a posterior. And they're like hula hoops. And these hula hoops sense if I'm tilting my head forward to the right, if I'm tilting my head back to the left, if I'm turning my head to the right, or if I'm translating to the right, or if I'm standing up or going up or going down like in an elevator. Well, the latter 2 are the otolithic organs, but the first 3 I was describing the semicircular canal. So going to the right is otolithic organs, going up and down are the otolithic organs. And she found that there's no difference with all those motions, and her group found that there are no differences in all those motions between the groups, vestibular migraine versus Meniere's versus normal controls. But when they looked at the combination of head tilt, she saw that the threshold of vestibular migraine patients was significantly less, meaning a vestibular migraine patient is much more sensitive if their head is tilted right or left than a standard migraine patient, normal person without issues, or a Meniere's disease patient. So theoretically, a Meniere's disease patient has swelling in their inner ear. There's something wrong with their inner ear. So she's controlling for all those variables. And it was a great, great study. And here she's looking at dizziness. DHI is dizziness handicap. This is motion sensitivity. This is headaches. This is Beck's anxiety scale. So she's looking at all these different variables and in essence finds that the vestibular migraine patients for sure, let me see here, have increased motion sensitivity. And she found there were these 2 groups, which I'm not going to go into because it's really nuanced. But in essence, one group definitely followed this scale of having more dizziness with increased thresholds. All of them had increased thresholds. Some of them didn't have increased dizziness per se, and other variables. Now, I want to go down here. Let me see. I believe it's in this section. Yeah. So you have a part of your brain called the nodulus and the uvula of the cerebellum. Your cerebellum is your balance center. And the nodulus and uvula is a deep part of the cerebellum, in the midline cerebellum, that affects velocity storage. What is velocity storage? If I were to turn myself to the right, or somebody were to spin me to the right, my inner ear would discharge for about 5 seconds, maybe 7 seconds. And then after that, the inner ear would no longer be sending signals that I'm spinning to the right. But the brainstem perpetuates that inner ear signal of 5 or 7 seconds for upwards of 30 seconds. So that's called velocity storage. And it's thought that velocity storage is asymmetrical from side to side in someone like a vestibular migraine patient or someone who has Maladé-Barkman syndrome, because they always feel like they're rocking and bobbing. So one side is too overactive. And by Dr. King and her group finding that tilt thresholds, namely in the role plane, so this is tilt. And this is different from me turning my head right or left, or forward right, back left, because the tilt side to side incorporates information from your semicircular canals. So I have an anterior and I have a posterior. So if I tilt this direction, interestingly, the anterior and the posterior canals are going to get some activation, as do the otolithic organs. Remember how I said the otolithic organs sense if I'm translating right or left. So she in essence found that this tilt mechanism is what is affected in vestibular migraine patients, and this tilt mechanism relies on the velocity storage integrator in the brainstem and basically the cerebellum. And this one part of the cerebellum called the nodulus and the uvula is heavily dampening, or we can say modulating, velocity storage. So when we see reduced tilt thresholds, meaning you're a vestibular migraine patient, your head is tilted, and you feel it way faster than someone else, you're feeling things that other people are not feeling. Doesn't mean you're feeling things like you're hallucinating. You're feeling things much more in a perceptive fashion than others. And specifically, it's that the nodulus and the uvula of the cerebellum is, you could say, hypersensitized, or it's just overactive. And so when the nodulus and uvula are overactive, then that results in increased tilt thresholds, i.e., you're going to feel rocking and bobbing with the most slightest of movements triggering that sensation. And so analogous to going back to the migraine example, a migraine patient, seeing a fortification spectra, zigzag lines in their vision because their occipital lobe is overreactive. Here, we're seeing that with a vestibular migraine, that it's likely the nodulus and uvula of the cerebellum is overreactive. It's hypersensitized. Just as a migraine patient may have numbness and tingling on the right arm, it's because their parietal cortex is hypersensitized. So this was a great study, because in essence, her group found the cause, so to speak, of a vestibular migraine, or at least a significant part of the issue. So that's why this study is so profound, and now the studies need to be done with more patients, and the studies need to be done probably with Maladé-Barkman syndrome patients. But in essence, she has come out and said this is a way to say this is a vestibular migraine versus some other condition. So that's why this is so significant. And in summary, if you have a vestibular migraine, you need to know your cerebellum, part of your cerebellum is overreactive, called the nodulus and uvula. It's basically modulating this part of your brainstem called velocity storage abnormally, such that now you're feeling things other people do not feel. And I recommend all of you to go back and read this article. It's fantastic. They controlled for everything. Again, it's out of Harvard. This Science Direct article is actually part of the journal Nature, which is one of the top journals in the world, like one of 2 top journals in the world. So it's a really great study for those of you who are research nerds and really like to get into the specifics of it. So send me any questions you have, any thoughts, any comments. I'm going to be doing a Maladé-Barkman syndrome YouTube presentation sometime this week. I'm going to try and hit all the dizziness disorders again and further discuss these overlapping features of Meniere's disease versus vestibular migraines versus mal de débarquement. I won't go into it anymore because I think I already did enough. So thank you so much for watching. Have a great day.